falls in a premature infant without pulmonary surfactant, right? Yes, is the audio video fine? Can we go ahead with the first question? So all except the following are false in a premature infant without pulmonary surfactant, right? So basically this is a case of, right, IRDS, and we want to know that what is the true statement here, right? What is the true statement here? Fine. So if I look at the first option, remember, first of all, you should know that yes, very good evening everyone, very good evening. Yes, I hope the audio and video is fine, right? So I have just begin with the first question, which is about a premature infant who is born without pulmonary surfactant, right? We have to pick up the true, the correct statement here, right? Yes. So first thing is the surface tension less than normal? Remember, surface tension is a collapsing force. So we should all know that surfactant, right? This question was also asked as a, PYQ recently. So surfactant will reduce the surface tension. So what should be the relationship between surfactant and surface tension? It would be inverse, right? So more is the surfactant, less is the surface tension, and less is the surfactant, more is the surface tension, right? It's the reverse. Surface tension we also know is a collapsing force. It's a collapsing force, right? It's a collapsing force. But on the other hand, we know that lung compliance is the distensible force, right? How much the lungs can stretch. So if you look here, then remember, in this case, preterm baby, surfactant is less, although it is clearly mentioned without, right? So without or no surfactant or less surfactant, or let's say no surfactant, right? So naturally the surface tension is going to be very, very high, right? So is it less than normal? No, this is false. This is going to be more than normal, right? More than normal. Normally we say this also requires a revision of our Laplace law. Remember, Laplace law states in the respiratory system that P is equal to 2T upon R, right? So now P is the distending pressure. That means if I have a smaller alveoli, they require a higher distending pressure, right? They require a higher distending pressure. So large alveoli will collapse more easily than the small alveoli. No, this is again false, because remember, if this is a smaller alveoli and this is a larger alveoli, then what I can make out is, if this is R1 and this is R2, then R1 is less than R2, but on the contrary, I would require a higher distending pressure P1 more than P2, right? So if I'm not able to maintain the distending pressure, my small alveoli will collapse much more easily, right? Yes, that's right. And pressures due to surface tension in large and small alveoli are equal? Not at all, because we have just discussed that the smaller alveoli will require a higher distending pressure. If we are not able to maintain that, then remember, smaller alveoli will have an increased tendency to collapse. Fine. So what is the right answer? A greater than normal pressure difference between inside and outside of the lungs is required for lung inflation. This is actually the true statement. Also remember, with inspiration and expiration, what we simply say is that if I am doing expiration, then what is going to happen is, with expiration, the size of the alveoli will be lesser. The size of the alveoli will reduce, right? And with reduction in size of the alveoli, there will be a relative increase in surfactant concentration, right? So one of you is asking me in the chat that what is the difference between inspiration and expiration of the surfactant. So very simple concept. With expiration, the alveoli size is reducing. If the size of the alveoli is reducing, there will be a relatively increase in surfactant concentration, right? On the other hand, if I'm doing inspiration, my size of the alveoli is increasing. There would be a relative decrease in surfactant concentration, right? So generally we say during expiration, because of relative increase in surfactant concentration, the surfactant maintains the alveolar stability, right? Let's move on to question number 2 now. N-caffeinergic interneurons are most likely to be seen where? Remember, pain is a very important topic from physiology angle. You have to know it thoroughly. So where are the N-caffeinergic interneurons? Who releases the N-caffein, right? So if you just recap for me here, right? This is the dorsal horn. This is the ventral horn. Then what I can see is that if these are my slow pain receptors, then these are my C fibers. This is the DRG. They enter the lamina 2, which is also known as substantia gelatinosa. Remember, lamina 2 releases N-caffeins. So where is the lamina 2 or substantia gelatinosa present? Yes, the answer is not ventral horn, as some of us wrongly say. The answer is, of course, dorsal horn, right? Dorsal horn. Also remember here the gate control theory. I'm quickly revising with you. Very important. If you are stimulating the A beta fibers, which are going straight like this, then as these fibers are ascending, they will give a small collateral to the lamina 2. They will stimulate lamina 2, which will release N-caffeins, and these N-caffeinergic neurons will inhibit these pain fibers, right? Which fibers? These are your C fibers, fine? So remember, gate control theory, very important topic in physiology. Fast pain, slow pain. Pain is a hardcore physiology topic. You need to know about the pain, right? So that's the purpose of doing this question. Pain is an important topic in physiology. Moving to question number 3. This is a tricky question, although it is not difficult, I would say, but people sometimes get it wrong. So let's read one by one. Basically, in a normal cardiac cycle, you have to tell me which is the correct statement, right? So the maximum and minimum left ventricular pressures are virtually the same as the systolic and diastolic pressures measured in a peripheral artery. No. Remember, the maximum pressure in the left ventricle is going to be slightly more than 120 during systole, and the minimum, as we very well know, is actually nearly zero during IVR, isovolumetric relaxation phase. So it can't be same as systolic and diastolic, because remember, the major peripheral artery is aorta, and in aorta the systolic blood pressure is 120 and 80, right? Diastolic is 80. Second statement, left ventricular pressure rises continuously during filling. Please understand, the left ventricular pressure initially will not rise during filling. The reason is, if you could recap, and we have been doing it, that suppose this is the left ventricle, right? And let's say this is the left atrium, which is pushing the blood during filling into left ventricle. As the blood comes into the left ventricle, what is going to happen to left ventricle? The left ventricle has a very high compliance. It has a very high compliance. So this is the aortic valve which is closed. Because left ventricles are highly compliant, the pressure does not rise much. That is why the atria can keep on pushing the blood into ventricle, right? Greater than 90% of the end diastolic volume is ejected. No, 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 no. You all know that normal ejection fraction average value is 55 to 68%, right? So yes, once again, good evening, everyone. So average value is 55 to 68%. It is not more than 90%. Ejection fraction is not more than 90%. Most of us are on the higher side. We have generally 65 to 67, but it is certainly not more than 90. And actually the right answer is the mitral valve is open longer. Average value is 55 to 68, right? But most of us, or rather we say the range is, I'd like to recorrect here. So the range is 55 to 68, but the average value, most of us are on the higher side, which is around 65%, right? Now, mitral valve is open longer than the aortic valve. Absolutely correct. Remember, when the mitral valve is open, I am having ventricular diastole phase. But when the aortic valve is open, we are having the systole. And we all know that the ventricular diastole is 0.5 second, but on the other hand, the ventricular systole is only 0.3 seconds. So the correct answer is option number D, right? Yes, some of you are saying C. I hope you got the answer that C is why C is wrong and why D is correct answer, right? Moving on to question number 4. I have given you 2 or 3 calculation based questions because calculation based questions are the expected area of INICET. So that let's start with the first one. What is the calculated vascular? Yes, you are right. What is the calculated vascular resistance to blood flow through the kidneys from the following data? Systolic arterial pressure is 130, diastolic is 70, mean renal venous pressure is 10, renal blood flow is 800 ml per minute, renal arterial compliance is 4 ml per millimeter mercury. Please understand, I am asking you vascular resistance. So you have to use a simple formula here for me, which we have derived from Ohm's law, that R is nothing but delta P upon Q. Where if you could recap, delta P is over here, as we are talking about renal kidneys resistance, we want to know the mean renal arterial pressure minus mean renal venous pressure upon, yes, mean renal arterial pressure is same as MAP, absolutely correct. Yes, some of you are writing that, that's the same thing, that's true, upon Q, where Q is the renal blood flow. Remember, this is given to me as 800 ml per minute, right? This is given to us 800 ml per minute. Mean renal venous pressure is also given as 10. That means I need to calculate MAP. I think first step was that I wanted you to, this question is a good one because first I would like you to calculate MAP. So how would you do that? Because remember, I will not use systolic or diastolic pressure. I will use mean pressure because that's the average throughout the circulation, right? Throughout the perfusion pressure, average perfusion pressure throughout the organs, throughout the circulation. So that's first we have to use the formula dBp plus 1/3 of pulse pressure, right? Most of you are very well aware. You will tell me the answer immediately. That if you solve this for me, the answer should be, remember, diastolic is given as 70 plus 1/3 of, now pulse pressure is systolic minus diastolic. Let's solve this. If you solve this for me, you will immediately get the answer 90 millimeters of mercury, right? Now let's find out the resistance. Pretty easy now. So resistance would be, yes, 90 millimeter mercury minus 10 millimeter mercury upon 90 minus 10 millimeters of mercury upon, yes, and blood flow I have already told you is given to us as 800 ml per minute. Remember, compliance was just to give you as a distractor. That is not required. Now you solve this for me, you will immediately get the answer, which is 0.1 millimeter mercury ml per minute, right? So I hope you people got it correct. It had two things to it. First, I wanted to use the mean arterial pressure concept because that is the average or the perfusion pressure. Then I would like you to use a simple application of, yes, this is which law? This is our Ohm's law of hemodynamics, right? This is Ohm's law of hemodynamics, right? Let's move to question number 5. 80-year-old man presents with resting tremor, bradykinesia, and rigidity. His condition improves temporarily with administration of a dopamine precursor. Dopaminergic input from the substantia nigra pars compacta normally facilitates movements via its effect on D1 or direct and indirect pathways. Which of the following best describes the effect of dopamine on striatal neurons in these two pathways? So you have to just recall for me that what does dopamine used to do via D1 and what does dopamine do via D2. So I'll just make you go through the class notes picture, the workbook picture, if you would be able to recap for me. Let's quickly see that. So if you look at this picture, what I'm trying to show you is from the cortex, motor and premotor areas, the afferents are coming to the striatum. First, I have a direct pathway. Direct is always the shortest pathway. Via the striatum, I release GABA. I inhibit globus pallidus internus and substantia nigra pars reticularis, which was already releasing GABA, right? And finally, what is going to happen? The direct pathway is always stimulatory, indirect is always inhibitory. But please look at the upper part. Dopamine via D1. Dopamine via D1 stimulates the direct pathway, but the same dopamine via D2 inhibits the indirect pathway. That's the simple thing I'm asking you. So let's revisit the question here. So dopamine excites the D2 receptors in the direct pathway and inhibits the D1 in the indirect. No, that is wrong. So the answer should be dopamine excites the D1 receptors in the direct and inhibits the D2 in the indirect, right? Yes, I can see majority giving the correct answer. That's wonderful. Moving to question number 6. The following lab values were obtained in a 58-year-old man. The urine flow rate, again one of the favorite topics. You have to know the clearance, you have to know the clearance curves, you have to know the tubular filtration upon plasma ratio curve, which we have been doing. These things should be on your tips. Clearance is an expected topic in the exam, right? The following lab values were obtained in a 58-year-old man. Urine flow rate is given as 3 ml per minute. Serum creatinine and urine creatinine is given to me. Plasma potassium, urine potassium values are also given, 30 millimoles and 4 millimole per liter. But I am asking you, what is his approximate GFR, assuming he has collected all of his urine in 24-hour period. Remember, the clinicians use the creatinine as an index of GFR, which they call as eGFR or estimate of the GFR, right? So potassium is not required in this question. I just want you to use that clearance of creatinine is going to roughly give us an index of GFR, and in this question I just need to use the formula, which is U into V upon P. That's right, where I need urinary concentration of creatinine, plasma concentration, and urine flow rate. So urine flow rate is V, I think we all know that. P is the serum creatinine and U is the urine creatinine. Let's solve this out. So if I solve this now, I simply need to do 50 milligram upon 100 ml into 3 ml per minute divided by serum creatinine 3 milligram per 100 ml. If you solve this for me, you will easily tell me that the answer is none other than 50 ml per minute. Is it given? Yes, option number D, right? Moving on to question number 7 now. Which of the following is false about the withdrawal reflex? Remember, withdrawal reflex is mainly talked about in the animals, and if we talk about in humans, then naturally we are talking about the lower limbs. So if these are my lower limbs, representation, I'm walking like this, suddenly my feet lands on this pointed object, immediately I will flex my limb, the one which is landing upon the pointed nociceptive stimulus, painful stimulus, to remove the limb away from the painful stimulus. But simultaneously, I'm going to extend my other limb so as to support my body to maintain the balance, right? So is it initiated by the nociceptive stimulus, painful? Absolutely right. That is true. So this is true. Is it prolonged if the stimulus is strong? Of course. If the stimulus is very strong, then I will immediately remove my limb and I will keep on, maintaining the balance with my other limb till I am sure that I might not fall down. So it will be prolonged if the stimulus is strong. That's again true. It's an example of flexor reflex. Yes, that's true, because this is famously known as FWR, flexor withdrawal reflex, right? Flexor withdrawal reflex. Is it accompanied by the same responses on the both sides of the body? Not at all. In the ipsilateral limb, I'm going to do flexion. In the contralateral limb, I'm going to do extension. So is it accompanied by the same response on both sides of the body? No, this is wrong, because remember, ipsilateral limb, which is landing on the painful stimuli, I'm going to do flexion to remove the limb away from the painful stimulus. But in the contralateral limb, CL is contralateral limb, I'm going to do extension. Why am I doing extension? To remove the limb away. Yes, to maintain the postural balance. This is being done to maintain postural balance. Yes, D is the answer. And this is being done to remove the limb away from the painful stimulus. Let me show you a schematic to remove the limb away from the painful stimulus. Is it the flex is prolonged if the stimulus is strong? Yes, it simply means that if the stimulus is very high intensity pain, that means my contralateral limb will remain extended for a much longer time because the stimulus was very strong. That is the meaning of point B, right? I'll quickly show you a picture of flexor withdrawal reflex taken from the standard book. What it is showing me is, first of all, you should know that FRA means flexor reflex afferents. Flexor reflex afferents. These are type 3 and 4 fibers. Just look at this. They enter through the dorsal root ganglion. This fiber is now giving multiple branches. That is what is of interest to me here. In the case of ipsilateral limb, this is the representation of the ipsilateral limb. In the case of ipsilateral limb, we are doing flexion of the ipsilateral limb with the help of this inhibitory interneuron. I am doing inhibition of my A alpha motor neuron, which is supplying the ipsilateral extensor muscle. That means in the ipsilateral limb, I'm going to do flexion. And with the help of this commissural neuron, again I give branches. This time I am going to stimulate my A alpha motor neuron of the contralateral extensors. So in the contralateral limb, we will be doing the extension, and simultaneously I will be inhibiting the flexors. Simultaneously I will be inhibiting the flexors, right? Moving on to question number 8 now. Which characteristic or component is shared by skeletal muscle and smooth muscle? Remember, three types of muscle: cardiac, skeletal, smooth. You have to know about the excitation contraction coupling, which calcium is important in which muscle. It's a very important topic, right? So high degree of electrical coupling between the cells. Yes, would you think so? No, no, no. Skeletal muscle will not have high degree of electrical coupling. Smooth muscle has the gap junctions. That is the meaning of high degree of electrical coupling. Skeletal muscle does not have gap junctions. Troponin is only in skeletal muscle. Remember, in smooth muscle, multiple times repeat, we all know that, should be knowing. In smooth muscle, we do not have the troponin as the calcium binding protein. I have the calmodulin, right? Calmodulin is in smooth muscle. Elevation of intracellular calcium for muscle contraction. Yes, that's the right answer. But please remember, in the smooth muscle, we are seeing CICR, calcium induced calcium release, occurs in the smooth muscle and cardiac muscle. It is not seen in skeletal muscle, right? Please remember that. Spontaneous depolarization of the membrane potential. No, spontaneous depolarization occurs in single unit smooth muscles, such as the smooth muscle present in the walls of hollow viscera, gastrointestinal tract, genitourinary tract, right? So option number C is correct. Also remember, excitation contraction coupling. In the skeletal muscle we have the mechanical linkages. In skeletal muscle we call it as electromechanical coupling. In the smooth muscle we have the role of myosin light chain kinase, right? And remember, in cardiac muscle we have the electrochemical coupling, where the ECF calcium is coming in and then causing more release of ICF calcium, right? Skeletal is totally different. Kindly remember, skeletal is only ICF calcium has a role, and in skeletal muscle the dihydropyridine receptor behaves like a voltage sensor, right? So you have to revise that, very important. Extracellular calcium will be required in the cardiac and smooth muscle, and it is not required in skeletal muscle. In skeletal muscle only the ICF calcium has a role, right? Only ICF. Yes, C is the correct answer. Question number 9, again a very interesting question and can be, coming up in the exam. That is, a medical student is studying the fluid exchange in skeletal muscle capillaries in a laboratory animal. He determines that the fluid is being filtered out of the capillaries with a net filtration pressure of 10 millimeters of mercury. Remember, this is a question about Starling's forces. He obtains the following values. Now let's try to solve it without, using pen or pencil. Can I do that? Let's try it out. So capillary hydrostatic pressure 45, right? Just looked at this. This is a pushing pressure. It is trying to push the fluid out. Then interstitial oncotic pressure is also, it's a pulling pressure. It is trying to pull the fluid out of the capillaries, right? Pull the fluid out of the capillaries. CAPS is capillaries. So which two are in the same direction? If I ask you by now, you will immediately tell me 45 plus 10, right? These two are in the same direction. But which one is the opposing one? Capillary oncotic pressure, this is opposing. Plus I want you to calculate the hydrostatic pressure in the interstitial fluid, which I have not given you, but the net filtration pressure I have given you is equal to 10 millimeters of mercury. If you just look at this for me now, you will immediately be able to give me the answer. 55 minus 25, which is 30, minus 10 is equal to 20 millimeters of mercury, which is hydrostatic in interstitial fluid. Is the option given? Yes, answer is 20. Anybody who is, I'm afraid, didn't get it, maybe they can quickly see the picture of a tissue capillary to revise and recall the Starling forces. First, I have given you hydrostatic pressure in the capillary, which is 45. This is trying to push the fluid out, right? This is trying to push the fluid out. Then I am including over here oncotic pressure in the interstitial fluid, which is also trying to pull the fluid out. What was the value? 10. But then I have hydrostatic in the interstitial fluid, which is not given to us, but oncotic in the capillary is given, which is trying to pull back the fluid. So yes, which two are opposing? The red ones. Which ones are favoring? Now we simply use up the normal numerical data given to us and you will easily find the answer, right? Expected question in the last to last INICET question also came, so it's an expected one, right? Moving to question number 10, interesting one again. Yes, but you should not be taking net as 0, because remember I have given you net as 10, right? So you have to use the values. Normally also we say that the interstitial oncotic pressure is generally 0, but in this question I'm giving you 10, so you have to use the value which is being given by the examiner. A patient with SIADH, syndrome of inappropriate antidiuretic hormone secretion, will most likely show which of the following lab findings? Yes, let's try to do this. And what should be the answer? So in SIADH, there would be extreme amount of ADH. This high amount of ADH causes huge increase in water reabsorption. So let's do one by one. Dilutional hyponatremia. This will cause increase in ECF volume, but it will decrease the ECF osmolarity, right? Now please recap. If this is my normal cell, right, and this is my ICF, let's say this is 290 milliosmol per liter. This is, let's say, ECF. Now it has become, let's say, 220. Naturally the water is going to move from ECF to ICF. So the ICF volume starts to increase till the osmolarity of the ICF again reduces and matches how much? 220. So what should happen to the ICF volume? Will it decrease or will it increase? I think we all understand that ICF volume should increase. So what should be the answer? Hyponatremia with decreased plasma osmolality and increased ECF volume. I hope that you got it correct. Yes, you are right. Normally there is euvolemic hyponatremia, but we are talking about the immediate effect which happens immediately. Eventually there would be euvolemic hyponatremia. Immediately there would be dilutional hyponatremia. We are just using this fact, right? So question number 11, in the figure shown below, the shift from curve A to curve B would be caused by bank blood, carbon monoxide poisoning, myoglobin, or increase in 2,3-DPG. So it's an interesting question. Oxygen hemoglobin dissociation curve is one of the favorite topics. Every year in INI we are seeing one question from this, so you have to know it. Please understand, most of you will be able to give me the answer, I'm sure about it. Yes, the answer is none other than bank blood, because remember the blood in the blood bank is stored at a low temperature. That's the primary reason. The same B can also be the answer for rest 3 do not cause right shift. I'm just going to explain you one by one. Apart from this, the same answer can also be there for fetal hemoglobin, because remember fetal hemoglobin has alpha 2, gamma 2. Gamma chains have poor affinity for 2,3-DPG. Let's move to carbon monoxide poisoning. The carbon monoxide poisoning has two effects. First of all, it decreases the oxygen hemoglobin saturation, and also it decreases the glycolysis. So because of which there is decrease in 2,3-DPG. The figure is very interesting and peculiar. In carbon monoxide poisoning, the figure is like this. In carbon monoxide poisoning, the figure is like this. So what we are seeing is left shift with the decreased saturation. In myoglobin, it's an oxygen carrying pigment seen in red muscles or type 1 muscle. Remember, the myoglobin curve is extremely left shifted. If I make the curve of myoglobin for you all, then you should be able to recap. This is a curve of myoglobin which is known as rectangular hyperbola. So these four you have to know. They have been asking this, which is myoglobin, carbon monoxide poisoning, bank blood, or fetal hemoglobin. And naturally, the increase 2,3 DPG along with increase in temperature, increase in PCO2, increase in hydrogen ion, they all cause right shift. So this is absolutely, wrong, because this is going to cause right shift, right? So very interesting question and important one as well, right? Please do oxygen hemoglobin dissociation curve from the notes. Very important. Question number 12. A new drug is developed that blocks the transporter for hydrogen ion secretion in gastric parietal cells. Which of the following transport process is being inhibited? Anemia graph will be absolutely same, because anemia doesn't do anything to hemoglobin saturation. But if they are giving you oxygen content on the y-axis, then the anemia graph is right shifted, right? That is the only difference with decreased oxygen content. For saturation, anemia doesn't do anything to saturation. Yes, which of these drugs which blocks? I think we all know them. PPIs, proton pump inhibitors. So this has to be none other than primary active transport. Stimulation of which of the following would most likely result in, question number 13, rapid shallow breathing in response to pulmonary congestion? Yes, is it Herring-Brewer? Yes. No, it is not Herring-Brewer. Please remember, Herring-Brewer is a very simple thing. As we say, with prolonged inflation of the lungs, the vagal afferents are stimulated and they will inhibit the further inflation of the lung. That means prolonged inflation of the lungs, increased inflation of the lungs inhibits further inflation of the lungs. This is Herring-Brewer inflation reflex. Deflation is just the opposite. Prolonged deflation of the lungs inhibits the further deflation. Central chemoreceptor is not at all here. That is the role in medullary chemoreceptors. The answer is actually the J reflex here, which is the juxtacapillary receptors. Please remember, not only it causes apnea followed by rapid shallow breathing, the J receptors are the juxtacapillary receptors located near alveolar, bronchial or pulmonary capillaries. The main stimuli is pulmonary congestion, pulmonary edema, right, or pulmonary embolism, and the responses are the rapid shallow breathing, right, then hypotension and bradycardia. Remember, this reflex is very similar to a very important cardiovascular reflex, which is Bezol-Jarisch, right? You have to know all the cardiovascular reflex. You have to know all the respiratory reflexes. Again, an expected topic for the exam, right? Moving on to question number 14. A 35-year-old male rapidly ascends to high altitude, starts hyperventilating and develops respiratory alkalosis due to yes, increased stimulation of peripheral chemoreceptors by hypoxia, right? After several days, his tissues acclimatize and receive more oxygen despite alkalosis. Which of the following is the primary mechanism at the tissue level for improved oxygen delivery? So at the tissue level, remember what is happening. Is there decrease in mitochondria? No. At the tissue level, there will be increase in mitochondria. Also, you know that hypoxia is the major stimulus for the release of erythropoietin. Please remember, 85% of erythropoietin is released from interstitial cells in peritubular capillary beds. Remaining 15% perivenous hepatocytes. These are two main sources. Will the PO2 will be increased? No, 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 no. This will be decreased. The only correct answer is increasing 2,3 DPG, which causes right shift of the curve, thereby facilitating increased oxygen delivery to the tissues. Right? So please remember, I'm asking you at the tissue level, right? At the tissue level. Yes, most of you got it correct. That's wonderful. Question number 15. 80-year-old man is brought to the emergency with complaints of nausea, vomiting, muscle cramps, and generalized weakness. After descent, the kidneys act as a major, compensatory mechanism. Kidneys take 2 to 3 days to excrete the alkali, and then the pH normalizes. There is excretion of the bicarbonate by the kidneys, and eventually what happens is there is increased stimulation of the medullary central chemoreceptors, which increases the ventilation to almost 1.65 times, as we say, till the person is at the high altitude. After descent, it will take some time, 4 to 6 weeks, for the person to normalize. Yes, lab analysis reveals moderate hyperkalemia. Elevations of extracellular potassium will have which effect on the nerve membrane? Again, one of the important topics of physiology, resting membrane potential. And I don't think this is a very, very important one. Most of you are very well versed now. ICF potassium is around 150 milliequivalent per liter. ECF potassium I am taking as 3.525. Let me take as 5 milliequivalent per liter. Normally the concentration gradient is 145. In this case, the gradient, let's say this has from 5, it has increased to 7. If it increases to 7, simple question, earlier the concentration gradient was 150 minus 5, 145. Now the concentration gradient has reduced, only 143. So what will happen? This is delta C concentration gradient. If it reduces, less potassium will be able to go out. Because there is less potassium efflux, potassium accumulates inside. Potassium is what type of charge? Positive charge. If you add positive charge to the RMP, what will it become? It will become, yes, less negative or more positive. No, gradient increased ECF potassium means gradient is always delta C. That means 150 minus 5. Earlier it was 145, 150 minus 5. Now it is 150 minus 7. That means only 143. So 143 is lesser than 145, right? So it cannot be more. 147 is going to be more, right? So RMP becomes less negative or more positive. That is the correct answer. Membrane becomes less excitable. No, when the RMP becomes less negative, this is also known as depolarization. And depolarization means increase in excitability. Sodium conductance has no role here. RMP cannot remain normal and membrane will become more excitable, right? So the correct answer is option number A. No, RMP is less negative is same as RMP becomes more positive. Remember, suppose neuron has a normal RMP of, let's say, minus 70 millivolt, right? Just see this. Suppose it is minus 70 millivolt. Now you're adding some positive charge to minus 70. So let's say it becomes minus 62, minus 63. Has it become less negative? Yes. But what is the meaning of less negative? Why did it become less negative? Because I have added some positive charge. So if I'm adding some positive charge, that means I'm making it less negative or more positive. No. Option C cannot be the answer because sodium has, the main concept in RMP is the unequal distribution of the ions, role of the leaky channels, and the membrane permeability. The permeability of the membrane is maximum to potassium at rest. If 100 potassium channels are open, only 4 sodium channels are open. So sodium conductance will not increase, right? Sodium is coming from outside to inside. It has to come from outside to inside. If you are adding more positive charge over here, Remember, as the sodium wants to come in, the positive charge will start repelling the sodium, right? So sodium conductance will not increase. So I would like you all to know that, we are doing our app T&D also on the app. And for more further in-depth discussion, yes, you can also watch our back to basic videos, which are a crisp, concise lectures of our entire course. We are doing a regular test series as well. Plus we have the DAMS question bank GOAT edition and the revision course, which will soon follow, right? Best of luck from my side. God bless you all. Take care and do your best. And remember, I have something to show you as well, which is a problem will reduce only when you start taking action. So please don't delay, just keep on studying, and yes, have the faith in Almighty, right? So once again, thank you so much for patient listening, and I hope this session was helpful to you all, right? Take care.